Hello everybody, welcome to our first video in Principles of Pharmacology and Immunology. In today's video, we'll be covering absorption, distribution, metabolism, and excretion, which are all topics on your first exam. So let's start with some definitions that you may or may not have heard. So the two big ones I want to talk about are pharmacokinetics versus pharmacodynamics. This section in this video we're going to be talking about is pretty much exclusively pharmacokinetics. And pharmacokinetics is essentially, in simplest terms, what the body does to the drug. It's how the drug is taken into our body. It's how the drug is broken down in our body, how it moves through our body, and how it's eventually taken out of our body or excreted. And whereas pharmacodynamics, which we'll talk about in some future videos, is probably more traditionally what you associate with pharmacy, what the drug is doing to the body to elicit a response or change the body in some way. But both are important, and you'll learn about both throughout pharmacy school. So absorption, as you might have been able to guess, is how the drug is taken into the body. There's multiple ways. Traditionally, if you've worked community, oral is probably the most common. That's called an enteral route, essentially meaning it enters through an exterior hole in the body. Alternatively, that could also be rectal. But essentially, when it's taken in, a drug that enters through the GI tract can be absorbed partially in the mouth. It can be absorbed in the stomach, in the intestine. Whereas we have some parenteral routes. Think of this as more of an IV or a subcutaneous like injection. And there's different pros and cons that come to both that we'll talk about a little bit today. But just know those are some ways that drugs can get into our body and be absorbed. Distribution is essentially how the drug is moved in our body, and that's usually through blood. However, it can also be interstitial fluid, which can link up with blood. In even rarer cases, it can actually be through bile or lymph. That's a lot less common, but it's not impossible. Metabolism is essentially how a drug is changed chemically by the body. It's not always necessarily how the drug is broken down. It's not like we completely delete this drug from existence. Usually we're actually adding things onto the drug to make it not viable anymore. And usually we're also trying to make it more water soluble. And the reason for that is because of excretion. When a drug is made more water soluble, it's more likely to be excreted in urine, essentially to be removed from the body, to be filtered by our kidneys and then expelled. However, it can also be removed by the liver. This is a little less common. However, it is important, especially for more fat-soluble drugs. And we'll talk about why, because drugs can actually, when they're excreted by the liver, they can sometimes get reabsorbed by the bile and cycle through our body a few times. And we'll talk a little bit more about that later. So, like I mentioned before, multiple ways to administer a drug into the body for absorption. Enteral, parenteral, we talked a little bit about. There's also topical, things that can be absorbed, usually more fat-soluble products since our skin, our epidermis is more oily. That'll allow those kinds of drugs to get in easier. Topicals can include things for like arthritis and just general pain, things like NSAIDs. Inhalation, you might have also seen. To think like inhalers for conditions like asthma and COPD. A big reason we do some of these routes besides enteral and parenteral is with topical and inhalation, we usually want the drug working kind of where it's entering our body. Inhalation, we want it working in the lungs. Topical, we probably want it where we're rubbing it on our skin. So those are some advantages to those, although their absorption can be a little bit lower, just depending. Pros of enteral is it's probably the cheapest dose form of drugs to make. It doesn't have to be sterile like an IV does, or like some inhalations need to be. And they're generally very safe. However, absorption can vary. Think about when a drug moves into the stomach. Depending on the pH of the stomach or of the intestines, that can affect how much a drug is absorbed. Also, things like how fast food moves through your gut. If the drug is in your gut for less periods of time, it might not be able to absorb as much. But probably the biggest issue you'll learn, and one of the most interesting in my opinion, is the first pass effect. Essentially, when a drug gets absorbed the first time, it will move through our stomach and eventually be absorbed into the liver. And whether it enters in the stomach or the intestines, it's not the biggest deal. But some of it will go to the liver. And the liver is our primary site in the body for metabolizing drugs. So what can happen is when these drugs eventually go into the blood from the liver, you will find that they actually are already partially metabolized, and we get less drug overall, and that's called bioavailability. Bioavailability is essentially the amount of usable drug versus the amount of drug that was originally ingested or injected. And this is a problem really only for enteral. Um, Parenteral, on the other hand, especially IVs, have 100% bioavailability. Um, you can see here that this curve is a lot steeper for something that's injected versus an oral drug, an enteral drug. These are called areas under the curve, what this graph is showing here, and it essentially shows from the time a drug is injected what the maximum effect will be, and kind of the area under that curve will show you if it's higher, essentially that means the drug is having more of an effect on our body. And that can be a good thing or a bad thing. Drugs are typically designed around the fact that we want a specific time range in mind. So while oral is lower in this case, this drug might not need to have as high as an effect. Um, and that's just how we decide dosings, basically. Because having too much of a drug can be just as dangerous as not having enough of a drug. And that's a really big concept you'll hear all throughout your time in pharmacy school. Um, So like I mentioned before, pH is a huge factor in enteral absorption. Um, and that can be drug related. For example, if you were to take an antacid and lower the pH or raise the pH of your stomach rather, that might affect a drug becoming absorbed. But even like eating like a spicier food or more sour food that could lower the pH versus drinking like milk or something which can raise the pH of your stomach. That can factor as well. So there's a lot of things that can change it, including just being sick can also affect like your pHs. And pH isn't the only factor, but it's probably the most easy factor to do math on. And it's a factor that's relatively consistent among groups of people, whereas versus like absorption channels and things can vary genetically in people. So this is just the example I choose to use, but know that it's not just pH related. Um, Now there's different factors that can alter drug absorption. There's 9 right here. You don't need to know them all super in depth. I'll go through them briefly. Just understand these general concepts or try to. So first one is solubilization. Essentially, the smaller a particle is, the more crushed up it is, the easier it is to put in solution. Think if you've ever like mixed a powder with a drink, just to, like flavor water or something. The bigger clumps don't dissolve as much versus the smaller ones. That's essentially all this is. And if something's in solution, it's easier to absorb. Um, Formulation factors. So especially if it's like a reconstituted product, think like powdered amoxicillin you mix water with. That's been designed in a way to work essentially, absorbed in a certain place in the body with a certain amount of fluid. Again, that can be based on pH, but just depending on the drug company that makes that, that can change absorption depending on what their overall formulation is, not just the drug. The next thing is the concentration at the absorption site. Think of this as diffusion. The more drug there is in one part of the body, it's going to want to flow to another part of the body. So you want your concentration to be higher if you want more absorption. Blood flow at the absorption site, similar principle. Essentially, if there's more places for the drug to go, like more blood vessels, the drug will move through diffusion to more of those more often. Surface area, again, kind of the same thing. If there's more places for a drug to interact and absorb, it will absorb essentially. So you want high surface area if you want high absorption, and that's something our intestines are really good at. They're very high surface area organs. Gastric emptying, this is something I touched on a little bit before. Depending on how quickly food and other things move out of your stomach, if that drug is absorbed at the stomach, that's obviously going to be worse for that drug. However, something interesting about that is if your drug is, let's say, absorbed in the intestine, it won't necessarily change your absorption, but it will change your time to effect. Because if the drug doesn't get absorbed in your stomach, but it will in your intestines, and it can move through your stomach quicker, that means it'll get to your intestines quicker, and that drug will affect you sooner. Um, Food, like I mentioned, can change pH, but even food needs to be absorbed as well. That can mess with diffusion of some drugs. And also just things of that nature. It could coat the walls of your intestines and make it harder for a drug molecule to get absorbed there. Intestinal motility, similar to gastric emptying, in the sense that if you need a drug to be absorbed in your intestines, you ideally want it to be slow movement, because if it moves really fast through your intestines, then it probably won't get fully absorbed. Um, and finally, metabolism by the GI tract. Now, normally the GI tract doesn't metabolize drugs to a huge extent. It can a little bit. What this is more referring to is, let's say you have some bacteria in your stomach that happen to be able to metabolize this type of drug molecule. That can lower efficacy. In some cases, we actually target things like that in antibiotics, and the fact that we want these drugs to be partially metabolized by these bacteria because maybe that activates it. And that's what's called a prodrug. And we'll talk a little bit more about that as we go down the line. But as you can see, a lot of factors. Just kind of think of it like a logic puzzle in a lot of ways. If you ever get asked one of these, it's like if it's moving through me very fast, then I'm probably not absorbing it. Or if it has more chances to be absorbed, it will be. So just that kind of reasoning is what you need for this kind of thing. So a little more about absorption, especially across membranes now. Um, Essentially, I want to define some terms really quick. You've probably heard these in chemistry. If not, the term hydrophilic essentially means water soluble, whereas the term lipophilic means fat soluble. Alternatively, hydrophobic means it avoids water, and that typically means it's lipophilic, whereas lipophobic means it typically avoids being fat soluble and it's more water soluble. I might use those interchangeably. Just know that phobic is essentially the opposite as philic. Philic means good or likes, whereas phobic means like fears or doesn't like. So that's just kind of how you can think about that in case I use philic and phobic interchangeably. So small molecules will typically absorb across membranes. Alternatively, hydrophobic slash lipophilic molecules, aka liking fat, will also transport across cell membranes easily on the fact that they're um, phospholipids. So it's a very fatty kind of membranes our cells have, so fats will typically go to it. Charged molecules will be repelled. This is something pretty important that we'll talk about a bit. Um, so if it's small and it's fat soluble, it could probably absorb directly without a transporter. Um, and that's typically also called transcellular. Fat soluble molecules can just pass through one side of the cell to the other. However, if they're more hydrophilic or lipophobic, it's usually a paracellular route if they're trying to absorb to an area, unless they're moving through a channel. This will essentially move them in between the spaces in between cells. A concept is filtration will allow smaller molecules to pass through paracellular routes. However, bigger molecules might be excluded. This is pretty important in areas like the brain, where you want your small molecules like glucose to be able to pass through some tight junctions, but our brain is very selective for what can get in and out. So you don't necessarily want those large molecules getting through that can be harmful. Another concept when it comes to absorption is drugs can bind to carrier proteins. These are essentially expressed on the faces of cell walls. The drug will link with one of these, and then it will move through the cell while it is linked. And once it's on the other side of the cell, it will be able to unbind. It's a more unique type of transporter, but they do occur sometimes, so just something to be aware of. Um, there's also another process, which if a drug is, let's say, too large or not lipophilic, can move through our cells. Similar to drug transporters, it involves taking the drug inside of the cell and moving it to the other side. This is called endocytosis. Essentially, what will happen is a drug or other signaling molecule will form what's called a vesicle and trap a bunch of our drug molecules in the cell and move them through these little bubbles in the cell, essentially, and bring them to the other side. And that's usually a very active process that takes ATP. So the way our bodies are designed, it has to be like something really important to get to the other side, or that we want to get to the other side in order for this to really occur in bulk. And that's pretty much all I wanted to talk about. I'll go really briefly over these definitions. Passive diffusion just means it doesn't need energy. Again, usually smaller molecules and non-electrolytes, meaning not charged. Um, Filtration we talked about carriers, and we also talked about endocytosis. So just passive diffusion, no energy, active diffusion, energy. So something like, in most cases, the carrier proteins, in pretty much all cases, endocytosis will be active transport. So this is a really kind of important and kind of complicated concept. It has to do a lot with pH, and I'm going to try and simplify it to the best of my ability here. You'll only be asked maybe a question or two about this on your exam. This is called ion trapping. This is essentially a technique that drug manufacturers will use to determine where their drug will be absorbed and how to get it to stay absorbed. You might have noticed we've been talking about a lot of diffusion already, meaning a lot of these processes can go either one way or the other way if the concentrations shift. Um, but obviously we want as much drug to get into our body and stay in our body as possible. So how can we do that? And that's through ion trapping. So essentially, what this diagram is showing is it's showing different points in our body that have different pHs. So we have our stomach up here. The drug can move through our GI tract into our intestines. You can see there's a bit of a pH change there. Drugs can also absorb into our blood, our interstitial fluid, and our intracellular fluid. These all have a pretty neutral pH. So yeah, essentially, like I mentioned before, is a drug will move, or it can move through a membrane if it's not charged. And this is where acids and bases vary a little bit. So this is the protonated form of an acid right here. This is the protonated form of a base. The reasons these have protons is because the stomach's pH is so low. And if you recall, pH is a concentration of hydrogen ions. So essentially, these have been attacked by hydrogen ions to where they're pretty much always protonated right now. And when an acid is protonated, it has a neutral charge. So this can actually move back and forth between these membranes. But what happens is instead of moving back and forth, it will actually, when it's in the blood, since the pH is so much higher here, it might actually give up its proton because there's not as many protons around. It might donate them to a water molecule or something else in the blood, and all of a sudden it's charged now. It's just this acid form. It's an acid minus. And as you may recall, now it can't pass through a membrane because it's charged. And while it can pick up that proton again, it's very unlikely that it does, just because this environment is so much more basic, meaning it's trapped in our blood. Meaning, if we want an acidic drug that is used in the blood, a really good place to try and set up its absorption for is the stomach. Now, what's interesting is the base has a plus charge right here. Kind of covered that up. Let me erase this really quick so you can see that. Has a plus charge in the stomach, which means it can never get across the membrane in the stomach. But what can happen is as this moves through our GI tract, all of a sudden, this base loses its proton. You can see it's not bound here. I just drew it in just to show that it still exists because it's still somewhere. It's, again, just probably bound to a water molecule or something else now. All of a sudden, this base can move. But it's a little more interesting with the bases as these environments kind of all have the same pH. You can see the pH here is 5 to 8, but there's 7.4 across here. So at least in this scenario, for an enteral drug, it's actually a lot harder to trap a base in the sense that it can move between the blood, the interstitial fluid, or the intracellular fluid. But this isn't the worst thing in the world. There's a very little, because like as long as the drug is in our body, it always has chances of going where it needs to go eventually. Just some areas might take longer than others. Like if we need it in the blood, it can mess around in the interstitial fluid for a little bit. But eventually through diffusion, statistically speaking, it's likely to flow into the blood at some point where it can be used. And since there's so many spaces to diffuse into, we can have a lot of absorption here. And even though it technically can go back to the small intestine, just since there's so much more volume in the body and other places it can go, it usually won't. And most of it will move out of the intestine. Some will stay just based on the principles of diffusion. But we will at least be able to utilize most of it, even if it isn't trapped like the acid was. So I know that's kind of a lot. It's a bit of a complex topic. Just really what you need to take away is if the molecule is charged, it will not move through a membrane, and if it is not charged, it can move through really any membrane at once. That's all you really need to know about that. Now let's talk about distribution. That was pretty much all absorption we were just working on. High blood flow usually means drugs can be absorbed more. Again, that kind of goes back to our principle of diffusion. Also, think about blood being kind of the highway for everything in our body. Essentially, if we have a lot of blood vessels, a drug can get more places and it will be distributed more. Another factor is capillary permeability. If a drug can more easily get into different vessels, it will be distributed more if they're not super selective on what they take. High transfer from interstitial fluid into tissues. That's usually a good sign of drug distribution, as if essentially the interstitial fluid, similar to blood, is bringing drug to tissues, that will mean it has a higher distribution. And then binding to plasma proteins. This is really the only one that's does not help distribution. If a drug is bound to a protein, it is unable to work. It's essentially, just think of it, we'll just say this is our drug and this is a protein. And let's just say they have a bond of some sort, a hydrogen bond. Because if it's a covalent bond, it'll never really break, and then the drug is broken forever, essentially. So let's just say that's a hydrogen bond. It's stuck to this protein. It can eventually break loose, just depending on the conditions. It can be pH conditions, that can be a whole factor or a whole host of things. But essentially, if it's bound to a protein, let's say this is our receptor, this drug cannot go into this receptor while it's bound to this protein, meaning that essentially in the time it is bound, it is inert. However, there is a benefit to this, and this can be strategically used by drug developers. If a drug is bound to a protein, it won't be metabolized and broken down in the body, meaning that while this does have lower drug effect at initial administration, it can really prolong the half-life of these drugs. Bisphosphonates are a decent example of this. Those aren't necessarily protein bound. They more get stuck in your bone, but they're essentially drugs that can help with conditions like osteoarthritis and weakened bone density. Conditions such as those, we can give injections every few months. And these drugs stick around because they're essentially trapped by proteins or cells or just whatever areas they're trapped in. And that can really extend the half-life and make less administrations, which is like really beneficial in things like osteoarthritis, where it's like an injection, not exactly a pleasant administration route. So it's just something we can do less and use strategically. As for plasma proteins that are common, albumin's probably the most. It will bind weakly acidic drugs, technically, also hydrophobic drugs. So think drugs that are lipid soluble and also drugs that might have a proton that they can give up. Lipoproteins bind drugs a little less often, but they do sometimes. Since these bind dietary fats usually, they will also bind lipid-soluble drugs or hydrophobic drugs. And then there's alpha-1 acid glycoproteins. These will bind basic drugs. So you can think essentially acidic, neutral, and basic if you memorize these three. You might get one question on these. They're not the most important for this course, but just so you're aware. There's different sites which can absorb drugs easier. We alluded a little bit to this. The blood-brain barrier, the placental barrier of fetus, and the blood-testicular barrier, all are what are called like protected sites. And essentially the reason why is these are all sites that have a very huge influence on our body or growth or reproduction. And they have these tight junctions which really don't like molecules getting through to the outside. We have channels on them still, which can allow drugs to get through. Certain drugs and certain substances. But essentially diffusion in most cases, at least from the paracellular route, is pretty much disabled, just so we don't have any random thing coming into these areas. One more concept is that drugs are absorbed into parts of the body at different rates. The end result is kind of your volume of distribution. It's like, what are all the areas your drug can get to at what concentration? But essentially areas with really high blood flow will see a drug effect first, and they'll have higher concentration of drug effects first. So things that are very vascular, you have your lungs, you have your heart, you have your liver. And since there's so many blood vessels, just based on basic diffusion principles, the drug will first come to these sites, and then over time it will spread to your entire body, if there's enough concentration to spread to your entire body. For example, something like a fingertip may not be as vascular, so a drug might not really reach there in meaningful concentrations. But it will pretty much always be in these high blood sites. Um, so now let's talk about metabolism. I remember this was like a really overwhelming kind of series of lectures when we first started, especially the CYP enzymes. Don't freak out too much about it. If it's still Dr. Yan teaching it, he goes pretty easy on you with it. I'd say just know what I'm talking about here. Rewatch this a couple times if you need to, but I think I simplified this in such a way that it's pretty manageable. Um, so when consumed, drugs are lipophilic. This is essentially just to cross those membranes transcellularly to be absorbed and to stay absorbed. This is strategic. Um, but after they are metabolized, they typically are more hydrophilic. And this is like I mentioned before, so we can excrete them in our kidneys. So they go back in our blood. They can eventually end up in our urine. At least most drugs will. Metabolism can mean a lot of different things. I also alluded to this a bit. It doesn't necessarily mean destroying a drug. So we'll go through a few examples here. So in the case of aspirin, it is metabolized into salicylate. This will make its activity go down. This is essentially your idea of destroying, quote unquote, destroying a drug. It makes it so it doesn't work anymore. Whereas this drug here, irinotecan, I believe this is an anti-cancer drug, but it says right there. Its activity actually goes up when it's metabolized. Now this is what we call a prodrug. I think I used that term on one other slide. A prodrug is just a drug that's essentially activated by metabolism or activated by some kind of process which changes it. So when it turns into this SN38, this actually makes it active. So again, metabolism isn't destroying, it's just changing. Amitriptyline versus nortriptyline. These are both antidepressants. Some work better in some people, others work better in others. But essentially, when we metabolize it, it doesn't really make a difference. They can just go back and forth. They're still antidepressants. They still work. Granted, some will work better in some people and others work better in others. But more or less, they are so similar in their activity that they just still work. Now, metabolism can actually be bad in some cases. In the fact that acetaminophen Tylenol actually has a toxic metabolite when it's metabolized. And this only occurs in about 10% of reactions when Tylenol is metabolized, and that's why we have a certain like dose for it, just to make sure this doesn't build up too much. It turns into this N-acetyl P-benzoquinine imine, or NAPQ. You'll probably never see the long name of it again. Just remember NAPQ. Since that's toxic, that's actually kind of our body working against us in a way that this one pathway can lead to something that harms our body. Because remember, like our body is smart, it has a lot of enzymes, but it doesn't always know the reaction that's going to occur for every molecule it encounters. So when that happens, it's just kind of like, well, we made something toxic. And we do have ways to handle and destroy it, but just kind of an interesting thing that our body's metabolism can actually hurt us sometimes. But it can also help us. Clopidogrel is a drug for acute coronary syndrome. You'll learn more about probably next semester in therapeutics. It's a little toxic on its own, but it turns into carboxylate, so it becomes a lot less toxic by the time that's all said and done. There's different phases to metabolism. Phases 1 and 2 will change the structures of a drug, whereas phase 3 essentially changes a drug's interaction with a transporter, or it is a drug's interaction with a transporter in some cases. So essentially what phase 1 and 2 are doing is phase 1 is probably the most simple reactions. They will make a drug more hydrophilic. It doesn't usually involve cofactors, but sometimes it does, and it doesn't involve membrane crossing. Phase 2 has structural changes as well. It will be a lot more hydrophilic. This is essentially what we want to be our last step in most cases. Phase 3 are a little more rare, but they can still occur just depending on the drug. And every single phase 2 reaction requires a cofactor, so that's pretty important. And what I say when I mean cofactor is phase 1 will usually add on the addition of like a hydroxyl, so like an OH group, just something to make it more water soluble. Whereas phase 2 might add on like what's called glutathione, which is like a sugar essentially. And I believe I have some pictures of that on the next slide. But yeah, it'll add on these big like organic molecules that are very water soluble because they have a lot of oxygens, just to encourage moving it out of the body. And then phase 3 is literally just related to membrane crossing. No structure changes, no cofactors, nothing like that. So phase 1 reactions include 3 different processes: oxidation, reduction, and hydrolysis. It's essentially adding on OH groups or COOH groups, or turning OH groups that are already on the molecules into double bonded O groups, or even vice versa. It really depends on the molecule, really depends on the enzyme that's working with us. So phase 1 uses some esterases and hydrolases. So this would be due to like an esterase. Uh, this is more of like a hydrolase. But the primary mechanism and this will be super important. I remember this was super overwhelming when I first learned it, but this will become like second nature to you, honestly, pretty soon, because it is so common. You'll honestly probably learn most of this in MMP a little bit later in the course, and it'll make a lot more sense. If you wanted to, I've got some videos up right now. You could go watch that. I think it's my first video in the exam 3 review if you really want to get into this. But for right now, what you need to know is the CYP enzymes, the cytochrome P450 enzymes are just enzymes that are in your liver. And they just have different numbers that indicate their proteins. And these will metabolize the vast majority of drugs that enter your body. I believe they metabolize like 85% of all xenobiotics. And a xenobiotic is essentially just a foreign substance to your body. So these reside in the liver. Like I said, the liver is like the highest site for metabolizing in your body. And these are primary metabolizers. So these will like occur first because they are phase 1. The most common ones are CYP3A4 or 3A5. They're kind of the same. You'll probably see it written more as 3A4, but it doesn't really matter. CYP2D6, CYP2C9, 8 or 9, again, similar to 3A4. It's kind of used interchangeably. And CYP2C19, which is around here somewhere. I'll just write it in. CYP2C19 are just your most common. And you'll learn kind of what class of drugs these metabolize. Not super important for this. Just know they exist, and they're kind of doing their own thing. So esters can be essentially what's called transesterified to be a different ester. That just means that one group is moving on to another. These are those carboxyl esterases. Some esters may be more water soluble, which is again the point of this, so that can occur. Or even hydrolysis can turn them into carboxylic acids, which are more water soluble than esters in general. So again, just a little more notes on that. Again, the esterases and hydrolases really aren't as common. It's really just the CYP enzymes, but just be aware that they exist more than anything. Phase 2 metabolism will add hydrophilic groups, generally, like I said, like those big sugars. This is called glutathione. As you can see, there's like oxygens everywhere on it because it is like a sugar. However, there are like 2 exceptions. There are N-acetyltransferases and TPMTs. So this is an example of what a TMPT will do. TPMT will add a methyl group, and NATs, N-acetyltransferases, will add like essentially longer chains of organic like carbon chains. Glutathione and sulfur are 2 of the water soluble ones. And essentially, yeah, we generally want these to be water soluble, but in some cases we can use our more lipophilic molecules to be excreted by the liver, and that kind of just depends on the drug. Next, let's talk about transporters a little bit. This is more phase 3 now. That was pretty much all of phase 2 we just covered. It's literally just tacking on those organic molecules, or not always organic, but just very hydrophilic molecules. 2 major types of transporters in the body. We have our ABC, ATP binding cassette. These are what are called efflux transporters. These move things out of the cell. We also have SLC transporters. These move things into the cells. And those are influx or intake generally. So those are our 2 major classes. Our phase 3 metabolism can cause enterohepatic circulation depending on where the drugs move. I think I mentioned that concept briefly before. I may not have used the term enterohepatic circulation, but entero means intestine, hepatic means liver. So essentially that means liver and intestine circulation. And that's when a drug gets absorbed, gets partially broken down by the liver, gets excreted into bile in the intestine again, and essentially gets recycled through the body, which can metabolize it more. It can increase absorption in some cases. It really depends on the drug, whether it's like a prodrug or not. Because if it's a prodrug, if it gets activated by the liver, we can absorb more and more of it. If it's not, we'll eventually break more and more of it down. But due to the nature of phase 3 transporting things, um, that can potentially happen. And again, there's no structural changes in phase 3, but something important to note is since these transporters are a little bit complicated in phase 3, since drug molecules are so unique in their size and shape, is SLC and ABC channels will all require ATP. So next, some factors that can influence metabolism. Um, Sex, weight, muscle, or like muscle to fat ratio, body hormones, genetic variations, in enzymes and transporters can all kind of change how we do things. A few examples of this is like metabolism will slow with age, in older populations. Infants have a higher like water content than most adults, at least compared to like body weight. So doses can vary. Most of the time doses will be smaller because children are pediatric populations. In rarer instances though, doses can actually be higher in children just because they are so much more water soluble. Drugs may not absorb as well. And since drugs are typically lipophilic, we might need to have more to absorb into the body, which is just kind of interesting. Um, Liver diseases can affect all phases of metabolism. Uh, because obviously if we have a problem with our liver, our CYP enzymes might not work as well, our uh, organic molecule transferases in phase 2 might not work as well, or our transporters might not work as well. Kidney disease won't really affect phase 1 and 2, but there are transporters in the kidney for phase 3 as well. So if we have kidney disease, that can affect phase 3 metabolism. Um, the way that genetic variation occurs, or at least one way it can, are what are called single nucleotide polymorphisms. Um, Essentially, if you recall from, you've probably seen this in your previous biology courses, DNA is coded for in 3 base pairs. We have like our A, G, C, and then also T in DNA. Let's say this is a codon right here, a group of 3 molecule or nucleotides. If one of these gets changed to let's say A, C, C, this is an SMP, or a single nucleotide polymorphism, because a single nucleotide is changing. But now that this is ACC and AGC, this can code for a different amino acid, or it might, because there are some that repeat. But assume in this case it does code for a different amino acid, that will change the structure and function of these proteins, or it can at least. And in the case of metabolizing enzymes, because enzymes are proteins, it can actually affect how much we metabolize something. So these genetic variations based on these polymorphisms, which can occur somewhat frequently just because our genome's big, um, it can essentially change how we metabolize drugs. And a little bit of nomenclature, you won't, this is more of like an MMP thing again. Uh, these star numbers right here, you can see star 1 and then star 2 and then star 3. Star 1's always going to be what's called your wild type. That's just essentially the natural version of the protein, what it's supposed to look like. Um, However, if it's star like 2 or 3, it means there's a change in the protein. And that doesn't always mean the protein's going to work worse. In some cases, it can work better. That's a lot more rare, but it technically can. So just know if it's star anything other than 1, it's usually a mutation. And it's usually due to a single nucleotide polymorphism. Although, again, not always. There's always exceptions, but that's more of an MMP thing. Don't worry too much about that. Another thing is genes can be upregulated or downregulated. Upregulated means a gene will make more protein just because for one reason or another our body is allowing more of it to be produced. Downregulated is you make less. And let's say if these proteins, these genes are metabolizing enzymes, this can affect drug response. We make more of an enzyme that destroys a drug, the drug will have a lower effect. but alternatively, if we make more of a gene that activates a prodrug, then the drug effect will be greater. So again, more of an MMP thing. That's pretty much all your exam 3 is going to be on MMP, so you'll learn a lot more about that later. But just here, be aware that it's just a thing that exists. So finally, we can move on to excretion. Kidneys have a complex structure of blood vessels and tubules, which can essentially excrete waste and reabsorb necessary molecules like water. Obviously, when we urinate, we're excreting water, but we try to reabsorb as much of it as possible, just because since urine's a waste product, we don't really need to excrete something useful like water. It starts in what's called the glomerulus. Glomerulus. I guess I've never said it aloud, but essentially what happens is hydrostatic pressures will be used to push water and substances into the kidney tubules. Um, Whole complex system. Um, it'll go around this loop of Henle, and there's these convoluted tubules, and eventually through the collecting duct, where some things will move out, some things will move in. Not super important for this course, but essentially, um, limitations of the glomerulus are molecules that are greater than 5,000 Daltons. These are usually very large molecules. Most of the drugs we eat or absorb, I shouldn't say eat. I was thinking of like tablets and capsules. Um, Drugs we administer to ourselves are usually like less than 500. There are exceptions, especially for biologic drugs that aren't small molecule drugs. Cannot be absorbed by the kidneys. Charged molecules, again, are not able to cross membranes very easily, so they won't be absorbed by the glomerulus. Um, and another big one is drugs bound to proteins. So like our albumin that we talked about before, our low density lipoproteins, those cannot enter filtration because they are bound. Um, Age and sex both leads to changes in renal excretion. For example, females have lower renal excretion than males, and geriatric patients will also typically have lower excretion. Um, Drugs absorbed into the intestines may be taken back into the liver, but if they're lipophilic, they might go into the bile instead. Again, this is more on enterohepatic circulation. If a drug's excreted into the bile, because our bile can essentially be used to help us digest as well. However, if a drug just happens to end up there, it can be recycled, or it can also be excreted through the small intestine. Our liver is pretty good about reabsorbing bile. I think it does it about 90% of the time, but 10% ends up getting excreted. So that's another way a drug can get excreted, but generally it's excreted through the kidneys. But that's just another way that can happen, essentially. Um, Other way drugs can be excreted, breath is one, sweat, saliva, and breast milk. Actually, this is really important if you're interested in pediatrics. Knowing what medications a nursing mother is on will allow you to kind of know if a drug regimen should be changed because the product, whether it's a metabolite or the drug itself, may not be safe in the baby. Um, there's two different definitions here of clearance versus excretion. Uh, Excretion is removal of a drug slash metabolite from the body, whereas clearance also encompasses like metabolism. Essentially, clearance is the drug or metabolite is made inactive or it's taken out of the body. So a bit of a difference there. I don't think you'll get a question on that, but even though they're very similar terms, they're technically not interchangeable. So I thought I'd mention that here. Um, yeah, but essentially, you could model clearance with this equation, Ke being essentially the elimination rate constant, and Vd being the volume of distribution, which is essentially just the initial dose of drug over the concentration of drug at essentially the start time. So it's basically just showing at the start time how long will it take to get rid of this drug at the time it takes to eliminate it. So, I mean, pretty common sense thing if you think about it, or like, because I know with variables and equations like this can be a little complex, but essentially all it's saying is that how long will it take in total to clear this drug based on the starting concentration. That's all that equation's saying. Um, and Ke is actually a sum of processes because, like, again, it can be metabolism or excretion. This diagram kind of shows that, but it's essentially showing when all the drug is removed from the body. That's the clearance, and that won't really come back in this course. That'll be more important for future courses you have, but just thought I'd mention it here. And with that, I won't take any more of your time. Thank you so much for watching, and good luck on your quiz or exam.